Hi, I'm Professor Shakila Thangaratinam. I am based at the Women's Health Research Unit at Queen Mary University of London. I'm pleased to present the findings of a paper on timing of delivery in twin pregnancies, which has been published in the BMJ. The work has been done in collaboration with researchers across the world under the umbrella of the Global Collaborative Network, GONET. Worldwide, twin births is on the increase, with hospitals such as the Royal London caring for more mothers with twin pregnancies. Twin pregnancies could either be monochorionic, where the twins share the same placenta, or dichorionic, where the twins have their own placenta. Compared to mothers carrying one baby, women carrying monochorionic twins are 13 times more likely to suffer stillbirth, and this risk is increased 5 times if they carry dichorionic twins. In both monochorionic and dichorionic pregnancies, the risk of stillbirth increases with gestational age. However, the risk of neonatal death reduces as pregnancy advances. There is a need to identify the best time to deliver twin babies, which reduces the risk of both stillbirth and newborn death. Such discussions are often the focus of antenatal care of mothers carrying twin pregnancies. Currently, national and international guidelines widely vary in their recommendations on when to deliver twins, particularly in the period between 34 weeks and the expected date of delivery. Our team of researchers and clinicians, together with our collaborators across the world, address this very important question on when to deliver twin babies. We did this by systematically reviewing all evidence, both published and unpublished, in this area. We identified 32 studies involving 35,000 mothers with twin pregnancies. We assessed the qualities of these included studies. Having done that, we next proceeded to pool the results of these individual studies to obtain estimates for us to study the risk of losing a baby from stillbirth when pregnancy was continued to the next gestational age compared to the risk of losing the baby after birth of complications if delivered at that time point. We also studied the rates of complications in twin babies born at different gestational ages. Admission to the neonatal intensive care unit was the commonest complication encountered by these babies. We found that in dichorionic twin pregnancies after 34 weeks of gestation, initially the risk of neonatal death from delivery was higher than the risk of stillbirth when pregnancy was continued. The risks were equally balanced at 37 weeks. However, when the pregnancy was continued from 37 weeks to 38 weeks, the risks of stillbirth became higher than the risk of neonatal death. This resulted in an additional 8.8 deaths per 1,000 pregnancies. We observed that in monochorionic twin pregnancies, until 36 weeks, a strategy of delivery resulted in more neonatal deaths than stillbirths, and the risks appeared to be balanced by 36 weeks of gestation. Although we observed a 2.5 additional death per 1,000 pregnancies when delivery was delayed from 36 to 37 weeks of gestation, the findings were not statistically significant.
The findings show that delivery should be offered to mothers with dichorionic pregnancies from 37 weeks to minimize the risk of perinatal death near term, and that there is insufficient evidence to recommend routine delivery before 36 weeks gestation in monochorionic twins.
The findings of this study provide much needed information for clinicians when counseling couple carrying twin pregnancy regarding the risks of continuing the pregnancies versus delivering around term.